Right, we're just going to wait a few more seconds for a few more to arrive. You can see that attendee list increasing. Right. So thank you. Good evening, everyone. So welcome to our webinar here on enlarged prostate treatment. Now, my name's Damien. I'm your host for this evening. And I'm joined by our presenter and consultant urologist surgeon, Mr. Steve Garnett. So this presentation will be followed by a question and answer session. If you'd like to ask a question during or after the presentation, you can do so using the Q&A icon, which is at the bottom of your screens. Now, this can be done with or without giving your name, but please remember that the session is being recorded if you do provide your name. If you'd like to book your consultation, we'll be able to provide some contact details at the end of this session. But for now, I'll hand you over to Mr. Garnett, and he'll hear from me shortly. Thank you, Mr. Garnett. Welcome, welcome.
Great. Thank you, Damien. Yeah, so we're going to talk about prostate enlargement, or better known as benign prostate enlargement, or BPE. So next slide, please. It's just a little bit about me to start off with. I've been running the prostate service at Bellenden for quite a few years now, and have introduced a number of things, including originally laser surgery and also urolift surgery, and now aquablation, which we're going to talk a bit more about tonight as the newest sort of treatment in BPE, which offers a number of advantages. Next slide, please. So we're going to cover a little bit about prostate enlargement itself, then aquablation treatment, a little bit about urolift treatment, which I mentioned, and I think towards the end we just cover TURP, which is a long-standing treatment for prostate enlargement, which is still the most widely performed treatment and is widely available. And then, as Damien said, at the end we'll have some questions and answers, and we'll see how that goes and how many questions there are. And sometimes that can there can be quite a lot of questions, so we'll see what sort of response we get. Next slide, please. So BPE, or benign prostate enlargement. The prostate is a small gland that sits underneath the bladder, and in most men, as we get older, the prostate enlarges. Now, we call this benign prostate enlargement, or it used to be called benign prostate hyperplasia, or BPH, because the prostate is just below the bladder, and when a man pees, we pee out through the prostate. So as the prostate enlarges, this does cause problems with the waterworks. It's extremely common, affecting at least 50% of men from the age of 50. And then as we get older, more and more men get affected by this problem, so that by age of 80 and above, almost 90% of men will have some problems related to this. So estimates put it around 3 million men in the UK have what we call lower urinary tract symptoms, or LUTS, L-U-T-S, which are associated with benign prostate enlargement. So very, very common indeed. Next slide, please. So this is the underlying problem, and this slide, I think, is probably the most useful slide of all the slides here tonight. It shows you really exactly what's going on. So on the screen, you can see the normal prostate there, as I look at it on the left, and the enlarged prostate on the right. And as you can see, that's just below the bladder. And as the bladder fills up with urine, when we want to have a pee, we pee out, and the urine goes out through the prostate. Now, when the prostate gets enlarged, as in on the right, a number of things happen that causes a blockage to the flow of the urine out. So the flow gets less, and often, men say that it's more like a trickle than a good flow, and that they have to take a long time to have a pee, but also it takes time to get started. So that's what we call hesitancy. And there are secondary effects as well. So because the bladder has to work very hard to push the urine out, the bladder wall becomes thickened. And then what happens is we see something called bladder overactivity, or unstable bladder develop. So that is sort of sudden feelings of wanting to rush to the toilet, going more often, and getting up more at night. And also, as the bladder becomes tired, if you like, over time, or the muscle stops working quite so well, with this disease being there for a long time, then it can become quite difficult to empty the bladder, and then can leave quite a lot of urine behind, which can make them prone to urine infections. And eventually it might get to the point where you can't pee at all and can't empty the bladder at all, and might need an emergency treatment such as a catheter to relieve that. Next slide, please. So we don't know exactly why people get prostate enlargement, but it does seem to be linked to the hormonal changes in the body, because obviously hormone levels do change even in men. But what we do know is that prostate enlargement doesn't happen without testosterone. So for all men who have levels of testosterone, they will have that will cause the prostate to enlarge. So we're not really talking about prostate cancer tonight, but some men have treatments for prostate cancer that may make them not make the male hormone, or may block the male hormone. And that in that situation, the prostate will shrink, not just because the cancer is being treated, but because the testosterone also causes benign enlargement of the prostate. Next slide, please. So as I've said, when the prostate gets enlarged and it blocks the way out of the bladder, the typical sort of symptoms are difficulty getting started when you want to have a pee, going more often, not fully emptying the bladder, getting up more at night, and often a bit of a stop-start pee and dribbling on a bit at the end. Next slide, please. So obviously the advice is, if you're worried about symptoms, then see your doctor in the first place, and your GP can arrange basic investigations and often start treatment. The sort of first line treatments are usually tablets and things that your doctor can prescribe. But if you're not getting anywhere with that, or the doctor is concerned, then your doctor may well send you up to the hospital for further tests, including something called a flow rate, where we check how well you are passing water and how well you're emptying your bladder, checking things like your prostate size. Often we do something called a PSA test, which again is a test looking towards risk of prostate cancer, and then also further tests that may help us choose which treatment's going to work best for you. Next slide, please. In terms of treatment, for mild symptoms, often no treatment is required, other than you might be able to make some lifestyle changes, like reducing the amount of caffeinated drinks, or not drinking so much at night time before going to bed, that sort of thing. But if the symptoms are more severe than that, then there are tablets that can relax the prostate or shrink the prostate in size, which can help a number of men. But then not everyone finds that those are enough, or some people have side effects with tablet treatment and wish to look at a more permanent option, such as some form of surgery. So widely performed procedures include aquablation, which we're going to talk about a little bit more, TURP, as I mentioned, and the urolift procedure. And each treatment has its own pros and cons, and advantages and downsides. So it's really a question of finding the best treatment that suits both you as a patient and your prostate size and shape, because that can affect things as well. Next slide, please. So let's talk a little bit about aquablation, which is a relatively new but very impressive treatment, because it actually has far fewer side effects than some of the traditional treatments. So aquablation uses high pressure, high speed water jets to ablate or destroy prostate tissue from the inside, and by doing that, core out a bigger channel through which you pass urine, so taking the pressure and the blocking tissue away from the bladder. There's no cuts, no cutting through anything. It's all done with robotically controlled instruments that are placed down the water pipe and into the bladder through the urethra. So it's minimally invasive and robotically controlled. And because of the robotic element and also real-time ultrasound imaging, which we use, it allows us to be more precise, which again helps reduce some of the side effects. Next slide, please. So this is just a quick picture of the team and some of the equipment we use at Bennington Hospital to do the aquablation. And in the middle, you can see the ultrasound and robotic equipment that is used in the operating theatre. Next slide, please. So we're able to very precisely target and remove that blocking prostate tissue using computer mapping and a robotic arm. And what we do is we use an ultrasound probe, which gives us live real-time imaging of the prostate, and then map out how much of the prostate we want to remove or ablate using the high-pressure water. So it takes about an hour, so it's not very quick, but the patient, you would be asleep for that. It's usually done as a one-night stay, and it's usually done under a general anaesthetic, so you're not aware of anything. Next slide, please. So this is a diagrammatic representation of what happens to the prostate during aquablation treatment. And in a minute, we'll run this as a video. But what you can see in the main picture there is the robotic arm, which has been put into the bladder. So the tip of the metal instrument there is in the bladder, and the rest of the instrument is going through the prostate into the bladder. At the tip of the instrument, which is now currently in the bladder, that is where there is a little nozzle that fires out high pressure water onto the prostate. The green zone that you can see is the mapping we've done based on the little ultrasound image in the little window there. So the box, the window there, and the right bottom is the ultrasound image of the prostate. And using that, we can mark out the limits of how far we want to ablate the prostate, which bits of it we want to be careful and preserve and not damage. And we can be very precise using this ultrasound and computer mapping. And then when we do start the treatment, you'll see that the high pressure water ablates, destroys the prostate tissue only in the areas that we've decided to ablate. So if we run the video now, you'll see that happening. So the high pressure water goes from side to side and ablates the prostate. This is an area called the bladder neck, and we adjust it there so we're not going so deep. And then you can see in the little window there again the washer going from side to side and the high pressure water ablating and removing the prostate tissue. So as the water goes in, it then goes through the bladder and back out again. That little video is just showing the water coming out. And as you can see, this is what we call the apex of the prostate, where the ejaculatory ducts are, and there's some areas here that we want to spare, so we don't treat the middle bit, we just treat the sides here. And that was just a picture, and that's doing the other side now in the little diagram there, little real life video, and you can see that just finishing now. Okay, thank you. Yeah, so that's very useful, I think, as a sort of showing you exactly what's happening during aquablation. Next slide, please. So aquablation, in most cases, does not affect sexual function, and that's really important because a lot of other treatments like TURP and laser treatment do affect sexual function in most men. Because there's no cutting, there's a reduced recovery time and less discomfort. So patients are usually in for one night with the catheter. There would be a catheter, a tube put in the bladder at the end of the procedure, and that comes out the next day. And because it's robotic and ultrasound controlled, as I've said, it's quite precise, more precise than existing treatments, and allows us to minimize damage to other structures. So risks of sexual dysfunction and incontinence are incredibly low. Next slide, please. Obviously, any treatment, including aquablation, does have some risks and side effects, particularly risks of urine infection. So we'll give you antibiotics at the time of treatment. The first day afterwards, it can be stingy and a bit uncomfortable to pass urine, and there might be a little bit of blood in the urine. But these side effects are usually pretty mild and settle down quickly. Next slide, please. So this is a good treatment for men with moderate to severe symptoms, not necessarily for people with mild symptoms, but if you've got quite troubling symptoms or very severe symptoms, or you've needed a catheter putting in, then this is a good treatment. But it's something that we would need to assess and talk about together to work out if that's the right thing for you. Next slide, please. So I'm just going to talk very quickly about TURP because lots of people will probably know about this treatment because it is a very widely offered treatment. It's been around for a very long time, 40 years or so now. And during this procedure, we put an instrument again down the urethra, down the water pipe, and use an electric current to cut through the prostate and remove the blocking tissue from the inside. It does work well to improve urinary flow rate, and it is a good treatment, and it is very widely done, but it does have recognized side effects, particularly in terms of affecting sexual function in most men who have it done. So it's finding the right treatment for the right person. For some people, that's not a big issue or concern, in which case the TURP is a very good treatment and very effective, although there are some limitations on the size of prostate that we can treat with the TURP. Most patients currently are in hospital for a couple of nights after this procedure. Next slide, please. Further treatment I wanted to talk a little bit about tonight was the UroLift procedure. This is what we would call minimally invasive, very minor procedure, which is done as a day case, in which we put little clips into the prostate that pull the prostate tissue open to allow you to pee better. And these implants are permanent and they're metallic, and that allows the flow to improve and improves bladder emptying and improves urinary symptoms. It says local anesthetic. To be honest, generally we do it under a general anesthetic or sedation now. It can be done under local anesthetic, but often it's a little bit uncomfortable. I think most patients prefer to have it done under a general. Next slide, please. So again, I'm going to show a little diagrammatic video of what happens with the UroLift procedure. So this is trying to show you a schematic sort of picture of the prostate. So there's two lobes of the prostate there compressing the way out of the bladder. And what you will see in a minute when the video runs is that we fire little implants through the prostate that anchor on the outside of the prostate. And then we then tension those to pull the middle part of the prostate open to improve the flow of urine. That's people often say, oh, they look like treasury tags, these little UroLift implants, and they do. So let's just run the video, and it's much more obvious when you watch the video. So this is the instrument going down through the urethra into the prostate, and we deploy the UroLift instrument here and push the prostate apart, and then fire this little implant through that's then pulled back to anchor on the outside of the prostate, and then deploy the inner end piece that pulls or compresses the prostate, if you like, that pulls it apart from the inside. And we put a number of these in depending on the size of the prostate, usually about 4, but if it's a big prostate, sometimes more. And as you can see, by doing this, we're opening up the water pipe or urethra and creating a bigger channel through which you can pass your urine. Because there's no cutting or destruction of tissue, it's a quick procedure with very few side effects. I think it's only fair to say that's the view afterwards. You can see on the left the blocking lobes, and on the right the lobes have been pulled apart, and that's looking straight ahead down the urethra into the bladder. So that's the view that I would get during the procedure and after the procedure. So what I would say about UroLift, it's a good treatment. It's, as I say, it's day case with minimal side effects, but I think it's fair to say it's not as durable, as long lasting as some of the other treatments that do remove more prostate tissue. And it's not suitable for very, very large prostates or men with very, very severe symptoms. But it is a useful treatment, and certainly many men find it very effective and helpful. Next slide, please. Okay, I think we've got a little patient feedback video now. We're going to just run through one of the patients we treated last year who kindly has done a little video to explain his experience. So we'll just run that now.
My name is Philip Ralph, and I was a self-payer for aquablation, which was completed on the 11th of December 2023. Matter of chance, I saw an information about aquablation that I felt was only available in America, and to my surprise I saw some information that Benenden Hospital in the UK actually offered this procedure, which was robotic and offered less side effects and a better recovery chance for me, as I was concerned that I did not want to have a catheter for the rest of my life. Aquablation has made my life back to normal. It has given me my life back. I no longer have a catheter. I don't have any symptoms. I don't have any incontinence. I'm able to urinate absolutely perfectly. I don't have to go to the toilet frequently. It is as if I'd never experienced any problems. I am fully recovered and I am so happy I chose Benenden and aquablation.
Okay, and I think that's the end of what I wanted to say. So I'll hand back to Damien now, and we'll take questions.
Yeah, fantastic. Thank you, Mr. Garnett. Yeah, please feel free to post your questions in the Q&A box. We've got a few here already, actually. So let's begin. So we've got an anonymous attendee who's said that he's been diagnosed with overactive bladder syndrome, and with a moderate prostate enlargement. I am on medication, but wonder if any of these treatments would help.
Yeah, so overactive bladder syndrome, it can be associated with prostate enlargement. And by that, I mean enlargement of the prostate can cause some of those symptoms, but you can also have overactive bladder problems without prostate enlargement. So I think in that particular case, we'd need to do some tests to work out whether the prostate was the underlying problem. Because just because you have a bit of enlargement of the prostate actually doesn't mean it's necessarily causing symptoms. So there are many men who have prostate enlargement who don't have a lot of symptoms. So I think the only way I can really answer that is to say absolutely, potentially these treatments might be useful for you in your situation, but we would have to do a few tests just to look into that in a bit more detail and work out if any of these were absolutely right for you.
Yeah, fantastic. Thank you. Now, I think you did touch on this. So we've got another anonymous attendee asking, when you mentioned the high pressure jet, is there any risk to other organs? But obviously, we did see that it went inside the bladder. Can there be any damage to the inside of the bladder from such?
No, because we're using ultrasound and also camera into the bladder. We can see exactly where the water jet is going. So no, we map it out, and when I say it's computer controlled, obviously it is, but there's a surgeon, usually me there as well with an override. So I can change it as things are going along if I had any concerns, but no, it's not going to damage any other organs.
Yeah. Okay. Good. Good to know. Good to know. Another question: would it ever get better without treatment? Now, that's a good one, actually.
Yeah, that's a
Left.
good one. Yeah. So the natural history of benign prostate enlargement is not really that the symptoms go away or get any better on their own, although you may get used to them. And particularly if they're mild or not bad, that's absolutely fine. I'm by no means saying that you must have treatment, because lots of men have relatively mild symptoms, which, whilst they're a bit annoying, they're not affecting their life too much, and that's absolutely fine. But no, they're not likely to go away.
Okay, no, thank you. We've got Paul asking, does the prostate tissue continue to grow after these operations, after this removal?
So after any of these treatments, whether it's TURP, laser, or aquablation, the prostate can grow back, but we do remove quite a lot of tissue, so it's uncommon for it to grow back enough for it to cause further problems. And to put that into some sort of context, then if you look at figures for men who've, let's say, TURP, which has been done for the longest, if you look at 10 years after TURP, 80% of men are happy with it. So, whilst it can grow back, the vast majority of men don't need further treatment.
Okay, fine, fantastic, thank you. So with acublation, another anonymous question, do you perform a biopsy once it's removed to check for cancer?
Yeah. So some of the tissue that is removed is sent off to be looked at under the microscope to check for cancer, yes.
Oh, fantastic. We've got a question. I've heard about a health supplement called Protect and Perform. Have you heard of this, and what are your views?
I haven't heard of Protect and Perform. There are, like many health issues, there are multiple supplements and claims on the internet that this is the miracle cure. And I am, a bit skeptical about those. I understand why people wish to avoid taking medications, and I understand why supplements sound attractive, but actually some supplements are dangerous, and many of them don't work. So I would just have a bit of caution. There's one supplement that has been shown to have some effectiveness in prostate enlargement, and that's called saw palmetto, and it's quite commonly used, particularly in Germany and France, as an alternative to medication. But even that has very limited evidence that it works. Whereas the medications that are out there have been shown to work. Now, some of them have side effects, and those may not be acceptable, but they have been shown to work, whereas most supplements do not have any proof that they work. And for example, one supplement that for years people took thinking it helped prostates was something called selenium. And people said, oh, this reduced the risk of prostate cancer. So there was a big trial done a few years ago, tens of thousands of people taking it, and it actually increased the risk of prostate cancer. So you have to just, there are downsides to things as well as upsides. So I think you have to be a bit cautious about it.
Yeah, absolutely, absolutely. Now you did touch on this particularly with TURP, but I guess maybe more with aquablation. Is how long does each treatment remain effective on average?
Yeah, so that's what I'm saying. The vast majority of people do not need retreatment in their lifetime, but overall figures for TURP are between 1 in 10 and so between 10 to 20% of people after or by 10 years have needed some further treatment.
Lovely, thank you. And actually, I think we've got just that gentleman. So Reg had TURP on January 19, and it's now confirmed that the prostate needs attention again as tissue has grown back. Is aquablation an option, or is TURP the only solution for him?
No, aquablation is potentially an option. It just depends a bit on, as I said, on a few other factors. But if he's had tests showing that it is the prostate that's growing back and not another problem such as scarring, then yes, aquablation would be a possibility. Yes.
Grand, thank you. So we've got David asking, oh, where's David gone? Are there any drugs which can help instead of the surgery? So you mentioned some sort of
there are
interventions earlier.
two widely used drugs. The first one is a drug that probably quite a few people on the webinar will be familiar with, which is something called tamsulosin. That works to relax the prostate and open it up. a little bit to improve the flow and the bladder emptying, and it is effective. It has a modest effect. In some men, it can cause some slight dizziness because it can lower blood pressure a little bit. But it is an effective tablet for it has a mild effect. And then there's another drug called finasteride, which works to shrink the prostate. And again, it is effective and it does work, but this can also have side effects, and this can affect erections in some men, and can, in a very, very few number of men, cause some other problems. For example, in a very few number of men, breast enlargement.
Right. Okay. Oh, thank you. We've got David asking, he's been told that because he's had laser prostatectomy, that he can't have the Urolift procedure. Is that true? And does that still apply for aquablation as well?
No, it's not. It's not true that you can't have. So obviously, I don't know the exact details. All I can say is that just because you've had one treatment in the past doesn't mean that you necessarily can't have another treatment in the future. So you may be suitable for Urolift or aquablation, but it would require some further tests, and particularly looking at your shape of your prostate, and what it looks like, I think, on the inside of your prostate, because that might be an issue. But just because you've had a laser treatment doesn't mean you can't have one of these treatments now, no.
Okay, thank you. Next question is, I've had chronic urine retention recently, and now have a catheter at present. I have a prostate of 110 grams. Would medication work, or is aquablation suitable to have it, as it's okay to have a local anaesthetic?
Um,
So is that a big prostate, 110?
so 110 is a large prostate, but not. Everything's relative, isn't it? So
Yes.
it's large, but by no means huge, or so a normal prostate is going to be up to about 30 mils or 30 grams in volume. A large one, we would say, is sort of over 80 to 100. So 110 is quite large, but not exceptionally large, and certainly would be suitable for aquablation. It's a bit large for Urolift, because the limitations are a bit more there. But so yeah, suitable for aquablation and possibly TURP. Medication wise, the two drugs I mentioned, tamsulosin and finasteride. Finasteride works to shrink the prostate, and both those drugs in combination potentially could help you. And it'd be worth trying those tablets and then taking your catheter out if there were no other factors, such as kidney damage, because sometimes people's kidneys can be affected when they've got to the point that they've needed a catheter putting in. And in that situation, the tablets aren't really going to do enough. But for most people who've ended up with a catheter, then starting tablets and trying to take the catheter out is a reasonable option. But quite a large number of people in that situation will end up with a catheter back in over the course of the next year. And for a lot of people, it is better just to have an operation.
Okay, lovely. Thank you. So Philip's asking, so Philip's had a Urolift in November 2018, and he's unfortunately back into the same situation where he's only getting 2 hours sleep before needing to go to the bathroom. What would you suggest? Can it be done without reference again, or NHS? Obviously, referring to a referral there.
So, I mean, as I sort of hinted at in the talk, the Urolift it is a good treatment, but it is quite likely that a significant number of people, after a few years, and for this chap, it sounds like 6 or 7 years, it is quite possible that you'd need further treatment. So options there might be to have the Urolift again, if that was something that you were interested in, but TURP or aquablation or other treatments are all suitable. Having had a Urolift doesn't prevent you having further treatment in the future.
Okay, thank you. Where are we? So So we've got another anonymous question. I have a prostate the size of an orange. He urinates 4 to 5 times a night. Flow is low and under review. Also, semen produced on ejaculation is very, very much reduced. Would all of the above be improved? I'm guessing in relation to aquablation.
Yeah, so with aquablation, it would improve your flow and your bladder emptying. The vast majority of men find that sexual function is not affected by aquablation. By that, I mean it's not negatively affected. It's difficult to make
Yeah,
promises about specific things like ejaculation, because there are quite a few reasons that that could have been affected, not just prostate enlargement.
yeah.
Other treatments such as TURP and laser treatments will definitely negatively affect, in the majority of men, ejaculation.
Fantastic, thank you. So Keith's currently prescribed tamalsolucin
Yeah,
and
tamsulosin. Yeah,
tamasulosin, that's what you mentioned earlier, and finasteride.
yeah.
Do they complement each other or work against each other? I recently stopped finasteride due to retro ejaculation, which seems to have resigned.
Yeah, so they do work well together. They work in different ways, have different effects. Um, Interestingly, on that sort of particular point, the
Yeah.
ejaculatory problems usually happen with tamsulosin, not finasteride, but finasteride can have other side effects. So, um, yeah, they do work well together, and but they, again, like most things, they can have side effects.
Okay, thank you. Another anonymous question. So, how soon after aquablation can this gentleman drive and go back to work, including vigorous exercise? So, I'm guessing he also likes to swim and run.
Yeah, I mean, the thing about all of these prostate treatments, the quickest recovery is going to be after the urolift, which is the smallest procedure. With aquablation, I would say, you do need a few days off driving, possibly, probably a week. We usually advise not to drive for a week, and you could go back to work after a couple of weeks. But if your work is very physical, or you're talking about going to the gym and things like that, doing very strenuous exercise, I would recommend you do leave that off for 4 weeks, because when you're doing very strenuous exercise or work, it does increase the risk of you getting blood in your urine after any of these procedures.
Yeah. Okay. Thank you. Actually, this has come up, and this is a question that intrigues me as well. So, this gentleman's asking whether you perform a scan to see how enlarged the prostate is before advising aquablation. And I was intrigued as to what type of imaging is it just ultrasound or?
So during the procedure, we use ultrasound, real-time ultrasound. Uh, the assessment of the prostate size and shape can be based on a number of things, from ultrasound to, obviously, we examine your prostate through the back passage as well, but also through the camera that we often do something called a cystoscopy, which is where we put a camera down the urethra and look at the prostate from the inside. So all of those, and then there are other scans such as MRI scans that we sometimes use. Particularly, we use the MRI if we're looking or have concerns about possible prostate cancer.
Yeah. Okay. Okay. Thank you. Does vasectomy exacerbate prostate enlargement?
Um, no, there's no evidence that vasectomy causes or exacerbates prostate enlargement. The, the only reason I sort of and is that's the straightforward answer.
Yeah.
There have been some studies in the past talking about whether there was any connection between vasectomy or other things such as ejaculation and risk of prostate cancer, but that's all rather unclear. But the bottom line is no, it doesn't cause prostate enlargement.
Okay, grand. So we got a question from Paul. At what point is benign prostate progression and surgery is recommended? For example, is it only when urine infections begin
No,
you consider
um,
surgery?
yeah, no. This is one of those decisions that I would say you and your uh, doctor or you and your urologist sort of make together, because it's not a question of me telling you in most cases that you've got to have an operation. This is um, it's not like a condition like cancer where you've got to have treatment to save your life. This is a treatment for quality of life. So it's really a question of what you feel about the quality of your life and how it's been affected by your particular problem. And that will vary from person to person, as will, the risks of treatment. Clearly, if you're very elderly and or have lots of other medical problems, then the risk of an operation is greater than if you're younger and fit. And you have to take all of that into account. And for some, as I said, some men might have symptoms that they're happy to live with, and other men might find them very annoying. So it's quite a personal decision that we would be able to discuss in clinic.
Yeah. Oh, fantastic. Thank you. Yeah. So Frank's asking, he's currently taking the prostate medication that you mentioned earlier.
Yeah.
And he's asking if he can stop taking that the moment that he's had his aquablation treatment, or is there
Yeah.
a
Yeah. I mean, if
period
you
of
have
time?
aquablation, you would stop. You would no longer take tamsulosin or finasteride. Yeah.
Fantastic. Sounds good. Um, few more. We've got an anonymous question. Is body weight linked to size of prostate, and would losing weight affect prostate?
Uh, there is. I mean, clearly, as a doctor, I'm always going to say that if you're overweight,
Mm.
losing weight is good for you. In many ways, not just the prostate, but your overall health and cardiovascular health, and risks of some cancers. Losing weight is going to be a good thing. Uh, as to whether there isn't really very strong evidence that it's specifically linked to prostate problems or prostate enlargement. No.
Okay, fantastic. And it looks like we've got the last one from Keith. How effective is exercise, such as pelvic lifts, to better control of the bladder?
Yeah. So pelvic floor exercises or pelvic floor muscle exercises strengthen the muscles that help um, control usually sort of leakage of urine. So obviously these are sort of exercises that lots of women do after childbirth, which can damage those muscles, and it can be very helpful for some men, and particularly some men who've had certain operations for prostate cancer. It can be very helpful to do these exercises. It can give you a bit greater control. So particularly, we talked earlier about a problem called overactive bladder. If you have overactive bladder problems, then doing pelvic floor exercises can certainly help with the urgency and control. In terms of just simply prostate enlargement, probably doesn't make a huge difference to passing urine, but certainly there's no real downside to doing them, and so it's worth giving it a go.
Okay, fantastic. So we've actually, Mr. Gutt, we've had a few more come through. Again, anonymous attendee. Is it correct that tamsulosin doesn't work if you have a catheter? Is
Um,
it still, is it?
yeah, well, I mean, if you've got a catheter, there's the so tamsulosin is to help you pee better. If you've got a catheter in, you're not
Oh, yeah,
peeing.
of course.
So
Yeah, yeah, I get it. Yeah.
it, um, if you have a catheter put in, you may be started on tamsulosin with a view to it helping or making it more likely for you to be able to pee when they take the catheter out. So that's one reason to be on tamsulosin if you've got a catheter in. But if you've done that and you still can't pee, there's absolutely no point being on tamsulosin when you've got a catheter in.
Yeah, absolutely. Understood. And we've got David. I think this will be the last one. I've reacted badly to tamsulosin and finasteride. Are there any other drugs that you could suggest or available?
Um, it depends on the type of problems you've had with those drugs. If it was so, what a lot of side effects are unfortunately what we call class effect, so there'll be the same reaction to other drugs in that class of drugs. So there are other drugs like tamsulosin, so alfuzosin, doxazosin. These are all similar drugs, and if your reaction was kind of specifically to tamsulosin, then you may be fine on those other drugs, but quite often, unfortunately, it is a class effect. So there is another drug like finasteride called dutasteride, and again, you may get on better with that. But unfortunately, most people, if they've didn't get on with tamsulosin, they probably won't get on with the other what's called alpha blocker drugs. And if you didn't get on with finasteride, you probably won't get on with dutasteride, although it's certainly worth a try.
Yeah. Okay. Well, thank you very much. Thank you, Mr. Garnett. I think that's all the questions answered. So, as a thank you for joining in this session, Benenden are actually offering a 50% off the value of your first consultation, a callback from your dedicated private patient advisor, and you'll also receive an email tomorrow with a recording, treatment information, and loyalty reward points, as well as updates on new and future events. We'd be really grateful if you could complete the survey at the end of the session, as this really helps us to shape future events. If you'd like to discuss or book your consultation, our private patient team can take your call up until 8 p.m. tonight or between 8 and 6 Monday to Friday using the number on the screen. Our next webinar covers a range of topics, and these can be found on our website. So on behalf of Mr. Garnett and our expert team at Benenden Hospital, we'd like to say thank you for joining us and look forward to seeing you soon.
Thank you.
Yeah, thank you, Mr. Garnett.
Cheers. Bye.
Bye-bye.